Hello, and welcome to this CME Academy module on breast anatomy, Part 1, specifically tailored for your exam preparation.
By the end of this video, you should be able to identify surface landmarks and the structural organization of the breast, describe its arterial, venous, and nerve supply, explain lymphatic drainage patterns and their clinical relevance, particularly for malignancy or infection. Lastly, stating the safe chest drain insertion landmarks. We'll be dividing the video into two parts. For this video, we will be covering the first two learning outcomes. Let's begin. Let's start off with the surface landmarks and structural organization of the breast. Before that, let's have a quick review of the important anatomical facts of the breast. The adult female breast is essentially a modified apocrine sweat gland. It's situated in the superficial fascia of the anterior chest wall, typically extending vertically from the second to the sixth rib, and transversely from the sternal edge to the mid-axillary line. It primarily overlies the pectoralis major muscle, and to a lesser extent the serratus anterior and external oblique muscles. Let's look at the key surface landmarks. First, the nipple. This is a conical or cylindrical pigmented projection, usually found around the level of the fourth intercostal space, though this position is highly variable. It's pierced by 15 to 20 lactiferous duct openings. Then, the areola. This is the pigmented circular area surrounding the nipple. It contains Montgomery's glands, which are modified sebaceous glands. These secrete a lipoid fluid that lubricates and protects the nipple, especially vital during lactation. Next up, the axillary tail of Spence. This is an important superolateral extension of breast tissue that projects towards the axilla, sometimes piercing the deep fascia. Clinically, this is a crucial area to examine as breast pathology, including cancer, can occur here. Lastly, the inframammary fold. This is the natural crease under the breast where it meets the chest wall, a landmark often considered in surgical contexts. Now, let's delve into its structural organization. The breast is composed of glandular tissue, fibrous stroma, and adipose tissue. While the skin and subcutaneous tissue is the first layer, the skin encases the breast, and beneath it lies a layer of subcutaneous adipose tissue. Next up, glandular tissue, the functional part or parenchyma of breast, made up of 15 to 20 lobes arranged radially around the nipple. Each lobe is a collection of lobules, which in turn contain the alveoli, the milk-producing units. Lactiferous ducts drain each lobe, converging towards the nipple. Just deep to the areola, these ducts dilate to form lactiferous sinuses, acting as small reservoirs for milk, before narrowing again to open onto the nipple surface. Following by that, we will discuss on the stroma or connective tissue of the breast, which provides the supportive framework. It is formed by the Cooper's ligaments and adipose tissue. Cooper's ligaments, also known as the suspensory ligaments, are fibrous bands extending from the deep fascia overlying the pectoralis major to the breast tissue, attaching to the skin. They provide structural support, a key clinical point. If these ligaments are infiltrated by malignancy, they can shorten, leading to the characteristic skin dimpling or tethering seen in some breast cancers. Adipose tissue is found both subcutaneously and between the lobules, or interlobularly, contributing significantly to the breast size, contour, and consistency. Next, the retromammary space. This is a layer of loose connective tissue found between the posterior aspect of the breast and the fascia covering the pectoralis major muscle. This space allows for a degree of breast mobility over the chest wall. A simple way to remember the layers from superficial to deep might be remembering the SSMRPP, which is the skin, subcutaneous fat, mammary gland, which include both the parenchyma and stroma, retromammary space, then the pectoral fascia and pectoralis major muscle. Now let's move to the arterial supply, venous drainage, and nerve supply of the breast. Understanding the neurovascular supply is crucial for appreciating how the breast receives nutrients, drains waste, and how conditions like pain or metastatic spread can occur. Let's begin with the arterial supply of breast. The breast has a rich, anastomotic blood supply from several sources. First, the internal mammary artery, also known as the internal thoracic artery. This is a branch of the subclavian artery. Its perforating branches, especially from the second to fourth intercostal spaces, supply the medial aspect of the breast. Moving on, the lateral thoracic artery, a branch of the second part of the axillary artery. This vessel supplies the lateral aspect of the breast. Next, the thoracoacromial artery, which also arises from the second part of the axillary artery. Its pectoral branches contribute to the supply, particularly to the superior and lateral aspects. Finally, the posterior intercostal arteries. These are branches of the thoracic aorta, typically the second, third, and fourth. Their lateral cutaneous branches supply the lateral aspect of the breast. A helpful mnemonic for the arterial supply could be, "I'm late please," which implies internal mammary, lateral thoracic, thoracoacromial, and posterior intercostals. Next up, the venous drainage of breast. It generally follows the arterial supply, forming an anastomotic network. The primary drainage is to the axillary vein, via veins like the lateral thoracic vein. The medial aspect of the breast drains into the internal thoracic vein. Posterior intercostal veins also contribute, draining into the azygos and hemiazygos system. This is clinically significant as this system communicates with the vertebral venous plexus, also known as the Batson's plexus, providing a potential valveless route for metastatic spread of breast cancer to vertebrae, ribs, and even the brain or central nervous system. Now, let's go to some important key points for the nerve supply of breast. Sensory innervation to the skin of the breast primarily comes from the anterior and lateral cutaneous branches of the 2nd to 6th intercostal nerves. The nipple areola complex, or NAC, are predominantly innervated by the lateral cutaneous branch of the 4th intercostal nerve, T4 dermatome. This is important when considering sensation preservation or loss after breast surgery. The skin over the upper part of the breast is supplied by the supraclavicular nerves, from roots C3, C4 of the cervical plexus. For the autonomic nerve supply, the sympathetic fibers travel with the arteries and sensory nerves. They innervate blood vessels, causing vasoconstriction/dilation, erector pili muscles in the skin, and the smooth muscle in the nipple, which causes nipple erection. A clinical pearl. The intercostobrachial nerve, often the lateral cutaneous branch of the 2nd intercostal nerve, T2, is frequently encountered during axillary lymph node dissection. If damaged, it can lead to sensory loss or uncomfortable dysesthesia in the axilla and the upper medial aspect of the arm. To recap, we identified key surface landmarks like the nipple, areola, and the clinically significant axillary tail of Spence, and explored the breast's structural organization, including glandular tissue, Cooper's ligaments, and the retromammary space. We detailed the arterial supply, from internal thoracic, lateral thoracic, thoracoacromial, and posterior intercostals, venous drainage, paralleling arteries, with Batson's plexus as a metastatic route, and nerve supply, mainly T2-T6 intercostals, with T4 for the NAC. In the next video, we'll be focusing on the lymphatic drainage of the breast, as well as the important anatomical aspect and consideration for chest drain insertion. Make sure to check it out after watching this Part 1 module. That is the end of our Breast Part 1 tutorial. Thank you for watching.